Okay, let us move into a brief section on making a personality disorder diagnosis in general. Sean Christopher Shea is the medical director at Dartmouth Psychiatric Hospital. He did a series of lectures at our facility a while back here, actually primarily related to suicide, risk assessment, documentation. Did a little piece on Axis 2 as well. And really one of the things Dr. Shea spends a lot of his time doing these days is traveling the country, providing expert testimony in cases where oftentimes, not always, but oftentimes, borderline patients have committed suicide, and family members are suing the clinician. Okay? And he would say, okay, forget from a clinical perspective. I'll talk about a clinical perspective in just a second. But he would say, from a liability perspective, okay, the most important thing that we can do to protect ourselves is to actually make the diagnosis and get it documented on the chart. Okay, he would say the most common scene that he has seen in courtrooms around the country looks a little something like this. Now the attorney says, well, gee, clinician so-and-so, I've got your medical record here, and this person's made 16 suicide attempts before they actually finally completed. And on Axis 2, you've got diagnosed deferred, 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 deferred. I mean, did you not recognize what you were dealing with here? I mean, so it's really viewed as a sign of incompetence by the courts when we've seen a patient for a period of time and continue to code, I don't know, I don't know, I don't know, I don't know. Okay. Then conversely, it's viewed as a sign of competence by the courts. When we get the diagnosis made, get it on the chart, document that we are either providing or referring the patient to the appropriate treatment that's available in whatever area that you live in. And if we do that, we're meeting the standard of care, which from a legal perspective is what our obligation is. We hate to say this, but I mean, if you work with a high-risk population and you're in the field very long, you're probably going to lose a person or two over the years. And we hate it, and it's sad, and we hate to see it. But from a legal perspective, it is not our job to keep people alive. From a legal perspective, it's our job to meet the standard of care. And making the diagnosis, getting it documented appropriately, is step one towards meeting that standard of care. So that's all from a liability perspective. From a clinical perspective, there's a number of reasons we believe this to be important as well. I could talk on this topic an hour. I don't have time to do that at this seminar. But I will just say that today, and it hasn't always been this way, obviously, but today, okay, every major expert in the field agrees that it is a good idea to actually make the diagnosis and tell the patient what we're treating them for. I often make medical comparisons in my mind, and I think probably most of you in the room at one point or another have sort of had the shoe on the other foot, and you have been to a doctor, and you have been the patient. Okay? Personally, I've had a kidney transplant, okay, so I can tell you I have a lot of experience being the patient. And I have to say, I wouldn't even consider receiving treatment of any kind, even taking medication, for a condition that the physician did not tell me what they were treating me for. I mean, it sounds a little bit ludicrous, doesn't it? Okay, but on one hand, I think this is kind of what we've been doing with these personality disorder folks for years. Well, let's just code this other and not talk about this. I think it's interesting that in an age that we are sort of lobbying for parity in the legislature to convince people that we're the same as other supposedly more medically based conditions, sometimes we still act in ways that reinforce those differences. Dr. Shea would say if you don't have the data, you have no business making a personality disorder diagnosis. I think that's the part everybody hears. Then he goes on to say if you do have the data, okay, you have no business not making a personality disorder diagnosis. When we get to the borderline diagnosis a little bit later this morning, I will walk you through that criteria in the exact way that we walk patients through the criteria when we make the diagnosis with them, using kind of the language that we use. And really, 9 times out of 10, they really do receive it pretty well.